2015 webinar. My name is Courtney Bentrott with the Center for Improving Value in Healthcare, and I'm very happy to be here with you today as we talk about enhanced community building and the reduction of preventable readmissions. Healthy Transitions Colorado is run by operating partners, the Colorado Healthcare Association, Telegen, the Colorado Hospital Association, the Colorado Medical Society, the Colorado Rural Health Center, the Colorado Behavioral Health Council, and Health Teamwork, and is managed by the Center for Improving Value in Healthcare. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, visit our website at www.healthytransitionscolorado.org. I have just a couple of things before we get started. The phone lines have been muted and will remain so throughout the webinar. We will be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the Q&A session after the presentation. This webinar is being recorded and will be posted to the HTC site so you may access this information again at any time without cost. I would like to quickly mention our upcoming Learning Series Symposium, Nurturing Community Collaboration, on October 16th, where the focus will be on enhancing the network of care via communication between community partners throughout the care continuum. Registration is open now at healthytransitionscolorado.org. Now, I'd like to introduce our guest speaker, Joe Sammen. Joe is the Executive Director at the Colorado Coalition for the Medically Underserved. He has been a part of the CCMU team for over 4 years. Joe has a passion for working to solve complex public health problems through systemic changes and has a long history of community organizing, both across the nation and around the world. Joe works to build authentic relationships with diverse organizations, communities, health leaders, and community residents across the state. As a leading expert on collaboration, health equity, and healthcare systems change, Joe advises and coaches state and local leaders and works closely with communities around the state of Colorado, providing technical assistance in facilitation, research, strategic visioning, and networking. Joe, I will now hand the presentation over to you.
All right, great. Thank you, Courtney, and thanks everybody for having me today. Those introductions always sound way too kind, so thanks for that nice introduction. Again, my name is Joe Sammen. I'm the Executive Director of the Colorado Coalition for the Medically Underserved. CCMU has been around for 17 years now, and our mission is to create opportunities and eliminate barriers to good health for medically underserved Coloradans. So we do that in a number of different ways. We have a large policy team that works at the Capitol. We have a robust sort of education and communications department that publishes issue briefs and publications to educate people about the issues. But we also partner really closely with community leaders and residents to support sort of community-driven health systems change. And one of the sort of central tenets of our strategy is that we really believe that health is local, healthcare is local, and that local solutions are needed to really create the healthcare system we need in communities across the state. So part of the work that we do to support local communities is we run and facilitate the Colorado Network of Health Alliances. So we've been doing this work for 3.5 years now. We launched the network in 2012 in the summer. And really, today I want to talk to you about sort of the details of the network, what we've been up to, and talk about why it matters to Colorado and to you all on this phone. More importantly, I think I'm really excited to just talk to you all about why collaboration is important to get you all excited about collaboration in communities. I know a lot of people feel like collaboration is sort of a mandate, an unfunded mandate by a lot of funders. It's hard. It's challenging to sit at the table and show all your warts and get people to agree to your vision and for change. But really in healthcare, I'm going to make the case that it's absolutely essential and that it can be fun too. So we know that collaboration is spreading, right? It's spreading all over the country. If you all have applied for any grants over the last 5 years or so, oftentimes collaboration is a component that people, that funders require of us. It's also sort of the new way of doing work in healthcare, and there's a lot of examples of this across the country. So just earlier this year, the Build Health Challenge came out from the Kresge Foundation, Robert Wood Johnson, and the Colorado Health Foundation, among others. And really, it's a challenge to get communities to think differently about how they approach upstream factors to health and to work across sectors and across agencies. 3 communities in Colorado were awarded as Build Health grantees. I just want to mention that, including one in Denver, one in Aurora, and one in Colorado Springs. And I'm going to talk a little bit about the role of community health alliances in Colorado and their part in that work. We also know of a large strategy that the Robert Wood Johnson Foundation has been up to, I think for the past 8 years or 7 years. It just wound down, called Aligning Forces for Quality, a very robust approach to community collaboration and using collaboration as a way to drive the Triple Aim forward in 16 communities across the country. That work has recently wound down, as I mentioned, but has been taken up by the Network for Regional Healthcare Improvement, of which Civic is a member, to sort of continue the conversation and the work around collaboration and health. And so they launched the Collaborative Health Network, which is essentially the infrastructure of Aligning Forces for Quality nationally, but trying to bring in a lot of other health collaboratives around the country. So we know that there's a sort of a national conversation happening around collaboration in the healthcare system in particular, and there's lots of different names for these types of collaborations. There's Collaborative Health Networks is a popular one that Henry's using, as I mentioned here. Another organization called Communities Joined in Action, which CCMU's community team is at their national conference right now, actually presenting about the network of health alliances. They call the folks in their membership body community health collaboratives. Essentially, the idea is that there's some formal body or entity in communities that play this neutral convening and collaboration role in their local geographies. There's one other initiative I want to mention, and that's the Institute for Health Improvement Scale initiative. It's part of the 100 Million Lives initiative that a number of foundations are looking at, and IHI is leading. And there's, I believe, 17 or 19 communities across the country that are part of the Scale initiative as well. And they're essentially looking at how do we build collaborative approaches and methodologies to healthcare change to further the Triple Aim in their communities. And 2 of the health alliances in the Network of Health Alliances are part of the IHI Scale initiative, including the North Colorado Health Alliance in Weld County and the Pueblo Triple Aim Coalition down in Pueblo County. So what are we up to in Colorado? We know that, I'm going to skip over this slide. We know that there's a lot of collaboration and formal collaboratives that exist in Colorado as well. And so it's this idea is spreading. It has spread over the last really 2 decades in Colorado. And we essentially have been sort of thinking about over the past 3 years as part of the Colorado Network of Health Alliances, why is this work spreading? And how can we bring all the collaboratives together to learn from each other and scale up sort of what works in local communities. So the Colorado Network of Health Alliances launched in 2012, as I mentioned. It has grown from 12 founding members to 28 formal members in the network. And I'll talk about the sort of collective impact that we've had across the state. But I think it's important just to know that these groups are working together. They've been developing relationships over the past 3 years. CCMU is the facilitator of this work, and we bring the membership together in quarterly network meetings across the state. We have mostly been doing learning together around best practices in collaboration, best practices in evaluating collaboration, financial sustainability of these sorts of entities, and also sort of community-based interventions like care transitions. Civic has spoken on one of our webinars as well, and Intelligent has, and others, right? So learning about what best prevention, what best healthcare intervention and prevention efforts work in communities. Recently, just this past July, the network membership really shifted from a learning collaborative solely to a formal doing collaborative, quote unquote. And so the group is very interested, and we're going to explore over the next 6 months or so developing a common agenda across the state. And that might include, agreeing to a menu of opportunities and interventions that all of the network members sign on to as evidence-based and biggest bang for their buck interventions in their local communities. And it might also look like some shared advocacy across the state, whether that's looking at how do we influence statewide systems change efforts like the state innovation model, et cetera. So it's a very exciting time for the network. The membership has really formalized and done some good work building relationships so that they're primed to take this next step moving forward. So why collaboration? Why is it spreading like this? The evidence is there that it's all over the place. And we really think at CCMU it's because of healthcare and health issues in particular essentially demand collaboration at the local level. So we know that there's this really good concepts from sociology, from the sociology field around different types of problems. And the 3 sort of types of problems that have been sort of laid out in sociology are simple problems. Essentially, we know simple problems, there's a recipe, and you can replicate it really easily, and you get the same result every time. A very simple example of that would be baking a cake, right? Depending on where you live in Colorado, there might be some tweaks to that recipe because of the altitude, but it's essentially simple. Once you discover it, you can replicate it, etc. There's also complicated problems. We know that there's expertise and training needed. There's right formulas and protocols for these complicated problems, and experience is really good. Once you have experience, you can get to the right result quicker, and it can be repeated, and you can get expectation of success. An example of this is building a skyscraper, right? There's sort of blueprints. There's skilled technicians who can pull it off. It's not an easy thing to do, but it's achievable, and those are complicated problems. The last type of problem is really there's a number of names for it. Complex is one. We know. Complex is one. We've also heard it called wicked problems. And so Atul Gawande, this slide shows, Atul Gawande wrote a great article in New Yorker sort of showing that healthcare change efforts are wicked problems in the country, in the United States. So what are wicked problems? Essentially, wicked problems are ones that have no right or wrong recipes or protocols that work in every situation. There's many outside factors influencing the solution and the situation. That every context is very unique. Every situation is unique. So this is sort of getting to that point of every healthcare system, every locale is has their own characteristics, such as workforce or different players and histories within the sector and within the healthcare agencies. And then lastly, there's really experience helps in these situations, but there's no way to guarantee success. And so the best example of this is raising a child, right? I have a 3.5-year-old and another kid on the way. I know that depending on what I do at any given moment, and depending on the influences that my kids receive in their lives, things will turn out the way they'll turn out, and I have little control over much of that. So we know that healthcare and healthcare systems change is a wicked problem, right? It's complicated. Examples of this would be, in the Denver area or in the metro area, high utilizer initiatives, right? We know that high utilizer initiatives demand multi-sector approaches and multi-agency approaches because folks who are high utilizers of the healthcare system have multiple chronic diseases. They have multiple social needs that have to be addressed. And so if you're trying to improve health outcomes of high utilizers and improve their care management, you really must address things like social isolation, poverty, substance abuse, things like transportation, housing, etc. You also must work with other healthcare agencies in your community. For example, you have to work with, if you're a hospital system, you really should work with another hospital or all the hospitals in your area, because if you don't really understand the true nature of the movement of those high utilizers through the system. You might chalk off a victory because one of the high utilizers that you've had is no longer coming to your emergency department or your hospital multiple times a year, when in fact they've just moved over 5 miles down the road to a different hospital system. And so that sort of example is showing that we really have to explore collaboration, and I'll get to what we mean by collaboration in a little bit, in a much more robust way, because it really the healthcare system and the sort of intractable problems we're dealing with really demand that approach. National leaders are talking about this concept of collaboration and putting some methodology and rigor to collaboration as essentially the last mile to achieving the triple aim. So early on in our sort of journey to achieving the triple aim in this country, and I'm sure you all, since you're partners with Civic, you are well versed in this concept, but the triple aim essentially is lowering healthcare costs, increasing population health outcomes, and improving quality of care and outcomes in care across the country. And essentially, early on, people thought that technology in particular had a lot of, it could get us almost all the way to achieving the triple aim, especially around making our systems more efficient and coordinating care and health information exchange, etc. What we're finding out is that technology can only get us so far, and so there's this sort of gap between where technology leaves us and the sort of large-scale systems change efforts we're making, including policy changes, and sort of the triple aim end goals. And that sort of gap is really the last mile, and the last mile in this equation is really about relationships, local context, and collaboration. And many people, some communities are starting to make some change and to tackle that last mile in very encouraging ways. And to this point, I think a lot of people have thought that essentially that last mile, the collaboration and the relationships happened oftentimes sort of by accident, or it just sort of happened to play out like that in communities because of a really dynamic leader, or because of whoever was there in that community was willing to put the resources behind it. What I'm here to tell you is that actually collaboration doesn't happen by accident. And that's one of the things that we're starting to really explore as a statewide network. We have been over the last 3 years through the Colorado Network of Health Alliances. Why does collaboration happen? When does it work? And how can we measure that effect? There's early indications I mentioned that collaboration can work in healthcare systems change. We have some great examples of that in Colorado. The North Colorado Health Alliance has been around for over 15 years as sort of a pioneer in this work, changing the way that healthcare system players work together and essentially changing the conversation and the equation around healthcare change in Weld County. There's similar examples of that in Pueblo with the Pueblo Triple Aim Coalition, Colorado Springs with Community Health Partnership, and many others across the state. And we really believe that these mature health alliances broadly as a concept are on the leading edge of that change in our state. So what are we doing to explore these concepts? So again, I mentioned 12 alliances launched the Colorado Network of Health Alliances back in 2012. This really was out of need and desire from community organizations and efforts that we were working with, including a group called Aurora Health Access, which we were really involved with 4 to 3 years ago since the founding of Aurora Health Access, and meeting with groups around the state who essentially told us we are doing really great work on the ground. We want to learn from our peers and our partners. We don't really know them very well. We've heard about these other health alliances or health collaboratives across the state, but we don't have formal ways of learning and building relationships with them. We also, and people would tell us, I really feel like I'm out on an island by myself. I feel isolated, and I want to be part of a bigger statewide movement for healthcare change. We also would travel around and meet with these organizations and be essentially amazed at how similar their structures, their governance, their strategies were, and really saw this opportunity to launch a statewide learning collaborative around exploring what does collaboration look like and how can we increase the capacity and efficiency. So for the last 3.5 years, I mentioned our goals are really around fostering this shared learning and collaboration across the network, increasing the capacity and efficiency of local health alliances. We know, again, I mentioned there's a method to this work, and so understanding that method and how to build those capacities has been a central role of the network, and that's through mentorship across the state, but it's also through technical assistance that we either give ourselves via CCMU's expertise, or we work with outside partners to get. We also are, I mentioned, sort of pursuing the statewide collective action around statewide healthcare systems change and triple aim efforts. And lastly, we're really trying to increase the visibility of this work and ultimately create a statewide narrative of change. So if you've heard of health alliances before, actually a number of your community partners in Healthy Transitions Colorado are part of health alliances or are health alliances themselves. Just to name a few, I already mentioned a couple of the North Colorado Health Alliance has signed on as a community partner, as has the Pueblo Triple Aim Coalition. South Metro Health Alliance down in Littleton, Douglas County area has as well. And I'm sure there's many others who are part of this work. Essentially, you'll meet these folks on the ground, and you'll see that this phrase really rings true. If you know one health alliance, you really know one health alliance. There's a lot of variability across the state in sort of tactics and health topics that they focus on. One group might be focused entirely on mental health, eliminating mental health stigma in the community and integrating behavioral health and physical health. Another might be focused really strongly on outreach and enrollment for Medicaid and health insurance. Another one might be working on tobacco prevention or obesity prevention, tobacco use prevention, et cetera. So it goes down the line. This is true. We know this. And there are some very clear similarities across all of the network members as well. So first, all health alliances in the network of health alliances have a mission, a broad mission, to improve access to care and population health outcomes. So they have this essentially a top-level purpose of making the health of all people in the population that they're concerned about healthy. So this gets at this sort of medically underserved concept, right? Everybody deserves access to care in the community and should have access to care, and so all health alliances have that as sort of their mission-driven purpose at the community level. Second, all alliances are using collaborative strategies, quote unquote, to drive change, break down silos, and improve coordination in their community. And then lastly, they're all bringing together key health system and also community leaders across sectors. So almost all of the alliances have top-level leadership of their healthcare agencies and health agencies at the table, either at the board of directors level or at the sort of leadership level. And many of them have leaders also in other sectors, education sector, business sector, et cetera. So what the heck do we mean by collaborative strategies? This is where I'm sort of going to transition a little bit into talking about what we mean by collaboration and what the method of collaboration really looks like. So going to the literature, there's some really good examples of clear definitions of what different types of collaboration are. Collaboration means a lot of different things to a lot of different people, and we've found it really useful to look at this concept as a collaboration spectrum. And so many people will call collaboration something that looks like the things on the left side of the spectrum. So networking is sort of a traditional, if you think about it, a resource sharing, sort of get to know you coalition that you might have attended in the past, where you have really low-key leadership and flexible roles. Your primary purpose in that case is information sharing about events, about programs, etc. And there's not really any joint decision making or leadership. Moving along the spectrum, all the way to full-on collaboration, this is high-level sort of mature collaboration around developing a shared vision and funding across agencies and institutions, having highly developed communication and consistent communication, a lot of high-level leadership and trust and productivity and sort of this long-term commitment to collaboration. And so all health alliances in the network of health alliances fall on the right side of the spectrum, anywhere from sort of cooperation, coordination, all the way to collaboration. And all of them also have a desire to move down the spectrum to be more mature health alliance, more mature collaboratives in their communities. Many of you also have probably heard of this concept of collective impact, which is gaining steam. It has been since a landmark article in the Stanford Social Innovation Review in 2011, I believe, which essentially brings some common language to an age-old concept that collaboration can work in communities. And the 5 sort of central tenets of collective impact are that initiatives that use collective impact as a framework in collaboration are developing a common agenda. They're developing shared measurement systems. They have this, one of the central tenets, really the keystone of this framework, I think, is this concept of mutually reinforcing activities. So you don't have to be doing the same thing, but your activities should be building off each other and aligning in really mature ways. And continuous communication, and then this concept of the backbone support. So many health alliances in the network formally or informally use this network and are moving towards using it, use this framework and are moving towards using it. We like to think about the health alliances collectively as backbone organizations in their geographies or in their constituencies. So let me give you some examples. I mentioned a few of these groups. This is sort of getting to the point of if you've seen one health alliance, you've seen one health alliance in the local community. So Aurora Health Access is a group that's been around for about 7 years. It's a community-based approach that was founded out of a community church and a community organizing platform. It's funded by grants. It has a formal board of directors made up of community organizations and many of the health systems in the area. They have had some very interesting success over the years, including catalyzing, being the sort of neutral convener in the neutral ground to catalyze shared data sharing across some major institutions in Aurora, which led ultimately to the Bridges to Care hotspotting project, which was a Center for Medicaid and Medicare Services CMMI grant. That project that just wound down earlier this year, which was targeting high utilizers of the emergency departments in North Aurora. Community Health Partnership has been around much longer, about 20. Actually, this slide is a year out of date, so about 26 years now. It's a group that includes on the board of directors essentially the CEOs of the major healthcare institutions in the Pikes Peak region, including Memorial Hospital, Penrose, the Peak Vista Safety Net Clinic, a federally qualified health center in the Pikes Peak region, the Public Health Department, and a number of other entities. And they essentially are these community healthcare leaders, and they have a broad coalition as well. They were so organized together as a collaborative over the past several decades that they bid on the RICO, the Regional Care Collaborative Organization in the Pikes Peak region, and received the bid. So they are the RICO in the Pikes Peak region. They also are financially sustained through membership dues of the organizations and grants. And so they have paid staff. I believe their staffing is up to 45 folks now, a formal board of directors. They're a 501c3, very high-functioning collaborative in the Pikes Peak region. And then the Chaffee County Health Coalition has been around for 2 to 3 years now. It was a initiative that came out of mostly the Public Health Department in Chaffee County, the Human Services Department, and the hospital down in Chaffee County and Salida. And they really felt like there was so much collaboration happening and coalitions that they wanted to come together to create this shared vision for change and shared agenda around prevention and healthcare improvement in the county region. They are still looking for some funding, but they've been keeping the work going. They have an informal leadership team and a group of stakeholders who are actually engaged, and they're essentially they're a group that's just getting started. And so I wanted to put them on there to show you guys an example of an organization or a health alliance that isn't as formal and mature as the other two on the list. So I mentioned the backbone organization really driving collaboration and alliances really being the backbone organization in their communities. We think of CCMU as sort of the backbone of the backbones, right? We're a backbone organization, but across the entire state of this larger network. And what we do, I mentioned we contribute tools and resources. We're a neutral convener across the state. We really don't have a stake in the game. We've allowed the network to build out their own priorities and needs and common agenda. And then we also provide connection to statewide partners, including folks at the Capitol and folks like Civic, organizations like Civic and others, to link to the local work. Members contribute this sort of concept of mentoring. Again, there's a lot of exciting new regional collaboration and coordination, and then also this idea of we're all in it together, right? This camaraderie. We're gonna achieve great things on a statewide level. I mentioned in July that we just formalized our membership agreements for the network, and so we have 28 alliances who've signed on as formal members. They have committed to these high-level principles, which really track directly to the definition of a health alliance. So again, improving access to care and community health outcomes of everyone, and engaging leaders across sectors in collaboration. They've also agreed to and signed on to these high-level True North goals. All Coloradans have access to care. The health system meets the needs of families and individuals in Colorado, and that we'll try to achieve health equity and eliminate health disparities. They've also agreed to these high-level commitments around collaboration, shared work, some participation requirements, transparency, innovation, and they've also signed on, and this was not of CCMU's incentive, the membership and the leadership team of our network essentially said we need to maintain and sustain this work moving forward, so we'd like to collectively pay dues to the network as well. So what the heck do these groups do in real terms? And I mentioned this concept of measuring collaboration. So we collectively developed this theory of change around what health alliances do on their local level, and thinking about what collaborative strategies look like at the local level. You can see on that left column the real strategies are around relationship building and relationship building activities and meetings, data aggregation and assessment on a community level, interviews and recruitment of stakeholders, leadership, and this concept of backbone and collective impact we mentioned. In the short term, that's really trying to change the preconditions needed for long-term change, right? So again, these concepts of authentic relationships, establishing trust, ability of members in a collaborative to articulate a shared vision for change, really coming to a shared definition of what the problem is and the metrics, and then coming up with some formal governance structure to be able to make decisions and pursue joint activities and funding, and have a collective approach in the local community. So what will that happen in the intermediate? We think in the intermediate time frame, we think that's going to lead to, and we've seen it lead to, internal policy changes of community organizations, for example. One great example would be if a community health alliance focused on really wanting to increase behavioral health screening across the entire community, for perhaps using the ACEs screenings for early childhood intervention or early childhood trauma. Internal policy change would be that essentially all the health agencies in that region started to adopt and conduct ACEs screenings across the entire organization, right? So that would be an internal policy change that could lead to long-term change. Community readiness around tackling the issue. We see this a lot around health equity, understanding the issue, understanding what we mean by health equity, and building readiness around that change. Access to health insurance, access to care is another issue around building will for that change long-term. Other intermediate outcomes would be strong leadership, external and internal to the Alliance, so building that leadership in communities, message mirroring in communities, around sort of what the mission is of the local level, embedded collaborative strategies, so actual collaborative programs, and then long-term community relationships. Those intermediate outcomes should track to long-term improved population health, lower costs, increased healthcare value, increased coverage and access, and health equity. There's a link between those intermediate and long-term outcomes. I think that's important that we are still articulating. We think it tracks pretty well, though, from short-term, intermediate to long-term, and there's some early literature that shows that some of this stuff works. So down to the bottom, these are some evaluation tools that alliances have been starting to explore to measure these intermediate and short-term outcomes. I'll just mention two. One is a social network analysis tool called Partner, which is over there on the right, bottom right of the screen. There's some good data to show that the structure of the network of the alliance that is developed, essentially how mature and strong the network is, and we're talking about how much people trust each other, how many actual relationships exist within a collaboration or a network. That could lead to there's early indications that will lead to long-term improved outcomes of that collaborative work. Another really great tool we've been using is called the Process Quality Scale, which was developed by a really great team of researchers out of the University of Denver here, led by Darren Hicks and Carl Larson. And essentially, it's a 15-point scale that looks at how high quality your process of bringing together people is in community. And they have some really good data to show that the more high quality a process is, a collaborative process, the better, regardless of the intervention that collaboration actually ended up picking, whether it was the diabetes prevention program or a patient navigation intervention or whatever, the higher the process, the more improved efficacy and duration of the health intervention over time. And this was over a 10-year period with collaborations here in Colorado. So some really exciting new ways to measure what we mean by collaboration and define it and see our impact on a local and a statewide level. So when you think about our collective impact at the Network of Health Alliances, we cover about 73% of the counties, 47. We cover 72% of the population, and collectively, these health alliances represent almost 900 organizations as an entire entity. Many of the health alliances provide direct services, including outreach and enrollment assistance. I mentioned patient navigation services. Many of them run specialty care referral networks or volunteer physician networks. And so the direct services provided to individuals is over 150,000 people in Colorado. And then thinking about sort of what other qualitatively, what other impact alliances make, we know that alliances, as I mentioned, provide this sort of backbone support for convening and programs and really try to drive the community toward action with this neutral lens around action and healthcare change. So here's a great quote from the Colorado Springs Regional Business Alliance saying that if community health partnership didn't exist, our community would have many more islands and our healthcare system would be much less efficient. So this community partner, and I believe the Regional Business Alliance is on the CHP Board of Directors, they essentially think CHP is creating the environment, the preconditions to break down those islands and silos across the healthcare system. Second, we know that alliances provide the systems perspective and a common vision for change. So I mentioned the Chaffee County Health Coalition. Their CEO, Bob Marasco, mentions the CEO of the hospital out there, Heart of the Rockies Regional Medical Center. He mentions the alliance has changed the focus tremendously on their vision of healthcare in the community. There's some really great, exciting examples of how that's happened in Chaffee County in a coordinated and community-wide way. And then down at the Mercy Regional Medical Center, Kathy Roberts says, at the meetings, I have these aha kind of moments where I realize that these two other organizations have an interest in something I'm working on. So thinking of, how alliances really help redefine the work organizations do and how organizations work together at the local level. So I'm going to stop there and leave about 15 minutes for a question and answer. I know that was a lot of information. I would love to have a conversation with the folks who are on the phone and entertain any questions, but also just hear your reactions and Would love to hear if you partner with your local health alliance or if you have ideas on how to improve this work.
Great. Thanks so much, Joe. You have shared with us a lot of great information today. And just a reminder, if you have any questions for Joe, please go ahead and type them in the chat box function, which is located in the lower left-hand corner of your screen. And Joe, I'll go ahead and kick off some questions for you. I love that you said collaboration doesn't happen by accident. And so I was curious, how did you keep the momentum going initially amongst the Alliance members?
Sure. Yeah. So we, with the network of health alliances, it's a little it's kind of interesting. I talked today, I think, on two levels. One was around the network level, which is trying to bring all of these health alliances together in a statewide network to learn and build relationships and visibility of the local work, and also try to achieve statewide collective action. The second level is around local health alliance work, right? And so all these health alliances are very expert in their local communities around how to drive and build collaboration and lead collaboration to achieve outcomes at the local level. So I think there's a lot of lessons learned from the local communities, and we have done some work in local communities to help facilitate these processes. We've led collaborations ourselves. It's definitely both an art and a science. I think one of the central tenets is to always have the value proposition of your membership sort of at front of mind, right? So leading with that value proposition as opposed to and identifying that value proposition through the needs and priorities and desires of the membership, right? So I think it's really easy for a statewide organization like CCMU to go into a local community or to work with local communities like the network members and say, this is what we care about. This is our agenda. We really think that everybody in the state should really focus on outreach and enrollment efforts because health insurance coverage is the most important thing, right? That we found that doesn't build trust and true value to participants across the state because only some people who really care about that will sign up, right? Our approach has instead been to identify the value proposition and the common pain points across all of the alliances. And early on, what that was building skills and learning across the state around these collaborative processes, right? People really had a hunger for understanding how does collaboration work, how do we evaluate it, how do we sustain it, and that's where we gained some traction. As we moved to becoming more mature and building relationships and understanding our work, we're starting to be able to then take the next step and say, okay, what if we all did work together on one intervention, to take outreach enrollment as another example? We really do all believe that this is really important, and so we're going to take that on. But we would never sort of take that as a top-down mandate from the statewide level. Instead, it's sort of organically arisen to the statewide level. I think that's one really important piece. The second one is building on and identifying early wins that are small enough to win but big enough to matter across the state. And so for the network of health alliances, that has been a number of different things. One has been developing this theory of change around collaboration. We worked really hard with the network membership and with outside experts to develop that theory of change, and found it as an early win that we felt like we could take on as a state, and also it was important enough to matter to local communities and to build some momentum. Another example would be all of these alliances across the state are funded by or are interested in being funded by health foundations across the state. And so through our connections and contacts in Denver with the Health Foundation leadership, we were able to broker the last 2 years a meeting between the Health Alliance membership and the leadership at 5 of the local health foundations across the state. And so that's a very clear win that we could build momentum around that says, okay, actually we do have some power as a state to be able to broker these relationships and have new conversations, and that'll embolden us to take bigger action moving forward, whether that's collective asks across the state or across regions, or trying to influence funding priorities in the future. And so I think having that sort of stepwise approach is really important in collaboration, so that people don't lose momentum and they build morale early and often.
That's great. Thank you. Looks like we're still waiting to see if anyone has any questions. I'm also curious, are there any other areas of Colorado that you're looking to expand the alliances to?
Yeah, I was just going to pull up this slide again. Sorry, I'm flipping back here. Here's the map again. So yeah, since this work has launched, I think there's been a lot of interest, essentially good traction and early wins and demonstrated impact by some of the leaders across the state in this work has led to other communities wanting to try this strategy out, right? So one example, recently last year, a group in Denver County launched called the Mile High Health Alliance, which is essentially a collaboration of the major healthcare systems and prevention efforts in Denver County. And they really looked to both state and national models of this work and said, why don't we have this in Denver? And we should do it in an exciting and in a real way. And so they're working on some really exciting initiatives around specialty care access for the uninsured, around targeting high utilizers of the healthcare system, around outreach and enrollment and integrated care. And so that's an example of a community that didn't have an alliance before the Network of Health Alliance was launched, and one that launched one and that's actually thriving in Denver this year. I think each local community is so different and has different capacities and resources. In some communities where there's white on this map, where there's not a health alliance in the county, sometimes it's just because the folks around the table collaborate really well together, and there's just not a lot of people there to have to bring together in a formal way, right? So in some rural communities, a formal health alliance or a formal collaborative just seems like extra work, and it would be duplicative of the sort of environment and culture that already exists. So I don't think health alliances necessarily are the answer for every community. I think the Network of Health Alliance membership and CCMU have committed to building when there's a need and a desire for a health alliance, either to strengthen a health alliance or launch a health alliance in communities where there isn't one. The network members and CCMU have both committed to supporting that process and launching one. So we're having a conversation right now actually with community leaders in La Junta who have a existing coalition around public health and especially around emergency preparedness, and they're interested in potentially building out their coalition to be more formal around healthcare systems change and population health improvement, and taking some of the expertise and the resources we know and have from the Network of Health Alliances and sort of scaling up their work. So I think the answer is sort of it depends. It depends on the local community. It depends on the will and the resources and the assets in the community, and also the need as to whether there's room or even if we need a health alliance in those communities.
Okay. So what would you recommend as someone that thinks maybe they might want to develop a health alliance, but they're not quite sure, and so they're kind of running through that thought process? What would you recommend as the jumping off point or the starting point for them? Where
I think we would love to talk to whoever that would be. CCMU, because we're the sort of neutral convener across the state, the membership has given us sort of authority to engage with folks about this work and understand and bring real sort of questions and issues to the broader network membership. We also have a very exciting and strong leadership team and decision-making process for the network that's just been established and developed in the last several months. And so those leadership team members are great assets. I think many of the folks who maybe wanted to launch health alliances probably know people in these local communities and in the local community work. And so getting that one-on-one coaching and mentorship and perspective from those folks is also great. And we're sort of here to play the role of connecting people who are interested in this work to the local alliance members, want to be perceived as sort of a gatekeeper to this amazing constituency and allow them to lead and to take opportunities and mentorship roles as their capacity and their interests and resources allow them. So I think we could play that point of contact role. We'd be happy to connect people to any of the local alliances around the state. We'd also be happy to provide some individual coaching and consultation around what the next steps would be.
Okay, great. Thank you. Okay, well, it doesn't look like we have any other questions coming in, so I will go ahead and end it there. Thank you, Joe, and thank you also for joining us. This was the 4th webinar in our learning series designed to complement our symposia. Please take a moment to register to join us on Friday, October 16th for the 2nd of 3 symposia to start building and putting community connections in action. Registration is available through our webpage and under Events on the Take Action tab on the right-hand side. We hope it has been a valuable use of your time and hope to see you all in October. This webinar has been recorded and will be available on the HTC website in the next few days. Thank you and have a great day, everyone.
Thanks.
Thanks, Joe.